My name is Dr. Amy Wachholtz. I am an assistant professor of psychiatry at University of Massachusetts Medical School and the director of health psychology at the UMass Memorial Medical Center. My work is primarily in the area of pain management, looking at the psychophysiology of pain management, looking at better treatment methods for pain management, and also looking at the areas of health and well-being that intersect with pain management, so particularly in the areas of pain and sleep, pain and addiction, particularly opioid addiction. Those are my primary areas of clinical and research work. Comorbid pain and opioid addiction is an extremely complex problem that is influencing how people interact with their pain medications, how people interpret pain, how people move forward with their pain management. And there are legal complications, there are ethical complications, there are medical complications with all of these. So some of my research particularly is looking at how do we best assess people with comorbid pain and opioid addiction, and so that we can develop better treatments. Because at the present time, we really don't have any good treatments for comorbid pain and opioid addiction, either on the pharmacological side or on the psychological side. The best that we've been able to come up with is looking at treatments that can treat pain and have been empirically validated to treat pain, and treatments that have been empirically validated to treat addiction, and kind of mushing them together. But we haven't really took a step back and said, well, first we need to find out a little bit more about this population, because this population is not just a pain population, and this population is not just an addiction population. They have unique needs, they have unique psychophysiological processes when it comes to triggers, when it comes to pain management, and so we need to take a step back and first assess what are the needs of this very unique population. And that's where my research started, was looking at the psychophysiological responses that people with comorbid pain and opioid addiction have when they're triggered by a pain experience. And so we asked people into the laboratory that had, they were either opioid naive but had chronic pain, they had comorbid pain and opioid addiction and were currently on methadone, or they had comorbid pain and opioid addiction and were currently on buprenorphine and naltrexone. And then we had a fourth group that had a history of comorbid pain and opioid addiction. They continue to have chronic pain, but they've been at least abstinent for their opioids for a minimum of 6 months. In our study, it was approximately 2 years with a standard deviation of 6 months. So most of our patients were either 18 months to 2.5 years out. And then we asked them a series of questions about their response to opioid use, their response to pain, what their mood was like, what their sleep was doing. And then we actually exposed them to a pain trigger. And we used a cold water test to expose them to a pain trigger and asked them to report when they first experienced pain, and then we also measured how long they were able to endure that pain, while also measuring some of their psychophysiological responses to the pain trigger as well, and asked then how they dealt with the cravings for opioids after they experienced the pain. What we found out was actually rather disturbing from a clinical perspective. When patients were exposed to had a history of prolonged opioid use, they were much more likely to be much more sensitive to pain and have much less tolerance to pain. Even though it was the exact same pain trigger that was given to everyone, the people that had the chronic opioid use had much less sensitivity and much less tolerance. So what this means is that they're going to have they're going to be much more likely to be triggered for pain. They're much more likely to use or abuse opioids or relapse into opioid addiction when they're triggered by pain. And the other concerning piece is that what we looked at the people that had the prolonged opioid abstinence, so people that had a history of being on chronic daily opioids, but then had been off of the opioids for a series of time, for at least, again, on average about 2 years, they showed the same pain sensitivity and tolerance compared to the opioid naive group. And so this suggests that even after people get off of chronic opioids, they're still going to continue to have much more sensitivity to pain and much lower tolerance to pain over time. And this is very concerning, especially if we're talking about helping people get on prolonged opioids without necessarily sharing with them about some of the long-term challenges that may come into play, particularly for patients for whom we're looking at more of a palliative care perspective and less of a hospice perspective, where they might be struggling with pain for a prolonged period of time. We should really help educate the patients and the providers about what what this challenge may be for them long term. It means that we need to be much more sensitive to the fact that they are likely going to need more pain medications in order to achieve the same level of pain relief in order to help them improve their functionality. It also means that what we really need to do is stop looking at either a 0 to 10 or 0 to 100 pain scale of saying how much pain do you have. What we really need to do is start prescribing from a functionality point of view rather than a pain point of view. So does increasing an opioid dose help the patient become more functional in their daily life? Does it help them engage with their family members more? Does it help them maintain their quality of life? Does it help them improve their cognition and general engagement? Because if it does not, and again, we're talking in the palliative care perspective rather than the very, very end of life, which is a very different story. But for the individuals that are trying to maintain their quality of life long term, or at least over the course of a couple of months, we really need to look at opioid prescribing as a level of functionality rather than just that 0 to 10 pain scale. So if someone is giving high levels of opioids and it's actually making the person less functional in their daily life, then that is not a healthy prescription level of opioids. The other thing we need to really consider is to look at adjuvant medications and other psychosocial interventions as well, which have a lot of empirical evidence behind them as far as helping to manage pain. There's a lot of evidence that shows that things such as acupuncture, meditation, cognitive behavioral therapy specifically for pain management, acceptance and commitment therapy, all of these things can have a very powerful impact on the level of pain that a person experiences and the level of pain that they report. So if we're able to address those areas, including those areas such as depression and anxiety as well, either anxiety about their terminal illness, about depression around that area, anxiety about the pain itself, because pain catastrophizing can also be a major issue related to the pain experience. All of these pieces come into play, and so we really need to look at a total pain perspective and a holistic pain treatment approach as opposed to simply getting out the prescription pad. Particularly in the other area of looking at pain and addiction and sleep issues, that's another area where we know that if somebody is not getting sufficient sleep, that is going to impact both their pain and their addiction. And what we really want to be sure about is we're not just talking about quantity of sleep, we're talking about the quality of sleep. So that's one of the challenges that we also have in the psychological and the medical communities, because oftentimes the medications that we have influence the quantity of sleep, but actually do not improve the quality of sleep. So helping patients take a step back, looking at sleep hygiene practices and healthy sleep practices, helping patients improve their quality of sleep as opposed to simply looking at quantity of sleep, so that we can help patients stabilize their rapid eye movement stage sleep, which impacts cognition, impacts patients' ability to problem solve outside of their chemical coping strategies that perhaps they've relied on in the past, helping them identify what pain management strategies they might be able to use to better target their pain. All of those are going to be critically important, and those directly relate back to the REM stage of sleep. The other really important component of sleep is what's called slow wave sleep. And the slow wave sleep is critical to helping patients improve their pain levels. So we know that when patients do not get sufficient amount of slow wave sleep, they're going to be much more likely to experience an increase in their chronic pain or their various pain levels. And so it becomes critically important to address, again, not just quantity of sleep, but quality of sleep for a patient, especially if they're struggling with both comorbid pain and opioid addiction. Part of that is helping them maintain as much as possible a regular sleep schedule. So helping them identify areas of the day when they're feeling more tired, helping them if they're taking naps, making sure that those naps are either in the 20-minute or in the 2-hour time blocks. 20 minutes is very good because it can help with catnap level sleep, help refresh someone, help give them a little bit more energy to continue on with their day. A 2-hour block of time would allow someone to get through a complete REM cycle. If someone lays down to sleep for about an hour, they're interrupting their that cycle, and then what ends up happening is they get disjointed sleep then later on in the day. So helping people really narrow their blocks of time from either 2 hours or 20 minutes. Other pieces of components are making sure that they have a quiet, dark room, and that may include things such as an eye blinder, may include earplugs, help them avoid caffeine, alcohol, or other drugs right before sleep, helping them because all of those things can also affect the quality of sleep. Again, we're not just talking quantity, we're talking quality of sleep. And all of those medications and drugs can help with that. Working with the physician and the prescribers to find out if there's certain medications that are better to take at night versus in the morning, so that to help manage sleepiness, because there's some 24-hour medications that maybe they come on stronger in the morning or they might come on stronger at night, and helping work with the prescriber to find out which ones are better to be taken in the morning and which ones are better to be taken in the afternoon. Some of the other pieces are helping patients not lie in bed at night or lie in bed during the day when they're not asleep. And again, we're talking more of an energy management strategy rather than a truly end-of-life strategy. But for the most part, if they're just laying in bed during the day and they're wide awake, that's actually increasing their time in bed, but not increasing their functional sleep. And so it actually diminishes the quality of sleep that they have when they do actually fall asleep. They're much more likely to be in sort of that catnap level stage of sleep rather than engaging in some of the deeper quality levels of sleep that they need to function better, both cognitively and physically.